Hello, everyone. Today, I'm very excited to welcome Dr. Stephen Ponder, an endocrinologist, a diabetes educator. He has lived with type 1 diabetes for many years. I know him from his approach to diabetes management called sugar surfing. I got his book early on in my LADA diabetes journey, and it really helped me with managing my blood sugar. So I'm really excited to have him here today. Welcome. Thank you for your time.
Thanks, Lynn. I appreciate it. And by the way, I have your book too, just to keep it equal here. Thanks.
Cool. Yeah, thank you. Would you like to give a brief intro about yourself?
Yeah, I'll keep it real brief. I've lived with diabetes, well, type 1, for over 60 years. I'm a pediatric endocrinologist. I've been doing that for over 40 years. I'm also a CDCES, and I've been that for almost 37 years. So I've been doing all three hats of diabetes for a long time. So my insights are from not just what I learned in medical school, but what I've seen with patients and families over all these decades.
Wow. So yeah, you've seen a lot. So do you, with later diabetes, I mean, my experience was that I was misdiagnosed as type 2. And I know a lot of people watching, I think this YouTube channel, they're either recently diagnosed as LADA or they are misdiagnosed or they're questioning their diagnosis. What would you say that somebody should know if they have been diagnosed with LADA or they are thinking that maybe this type 2 diagnosis may not be right because it's not, things aren't like, what's the clue maybe that things are not as they seem there?
I can give you a very interesting, relatively recent example of this. A good friend of mine who works in the same healthcare system that I do is a pediatrician. He's in his mid to late 40s, and he was diagnosed with type 2 diabetes. And he reached out to me largely because he knew I'd written the book. We started talking, and I knew him quite well, and he did not fit the criteria that you would think for typical person with type 2 diabetes. So I said, "Did you think about LADA? Do you think about that?" And he paused for a second and said, "No, I hadn't. I never even heard of it." I said, I encouraged him to ask his endocrinologist, "Why don't you just go ahead and do some of the proper testing for that?" A few weeks, about a month or so later, he gets back with me and says, "Yep, that's what I have." And part of this came from the fact that his oral agent that they were using for him, which was metformin, and we all know what that is, a very commonly used type 2
Right. Yeah.
medication, just wasn't cutting it. And his blood sugars were still a bit out of range. And so once they made the diagnosis of LADA, they got him on the appropriate therapy, much better off. And using some of the principles from my book, he's also been thriving there too. And that was not that long ago. But this happens all the time in medical practice. And to your point about why you have this podcast and why you wrote your book, it is everywhere. And I wish I could say it's going to go away, this misdiagnosis. But I'm being real frank with you, and I don't see it. I think so much is baked in regards to seeing the world as type 1 or type 2. It's going to be a long time before we have the ability to make a later diagnosis at the beginning. I really think it's going to take a while.
Yeah, yeah, that's very similar to what happened to me. Like I was prescribed metformin and I went on a very low carb diet and did a lot of exercise and took the metformin. My blood sugar got like it got better, like out of the really scary range. But then it over time it really started going back up again. And then I was given other medications that didn't work and then basically needed insulin. And I think that is like just so common that people assume type 2, especially if somebody presents at a certain age or something and they don't think it could be something else.
Absolutely. I had two patients when I was seeing adults in West Texas in their mid 50s, two women in their mid 50s who had been diagnosed with, initially, interestingly enough, one was diagnosed as type 1 and put on insulin medication. Oddly enough, this person went to see an adult endocrinologist who immediately took her off her insulin and put her on an oral agent. Interestingly enough, about a week and a half later, she went into diabetic ketoacidosis, admitted to the hospital. She heard about me. We lived in the same town. I started seeing her, got her back on insulin, did the proper testing. And now she had more of a much more advanced situation than being able to, to maybe even sometimes get off some of these medications. But she was definitely a LADA. And another 55-year-old woman, the same thing. About 3 weeks later, it was odd they were back to back. They weren't related or anything. But she became the initial woman became a very good friend. She still is to this day and has volunteered at our diabetes camp for years. And since I met her, so it's interesting how these things bring people together. But I see it all the time. I've seen it all my career in one way or another, either through direct patient contact or through just friends, as I mentioned earlier with that doctor I know.
Right. So you bring up the point that insulin is really the right treatment, right? If it's LADA diabetes, it's really a subtype of type 1 diabetes, and it's a pancreas that's not making enough insulin.
Correct. There is also a confounding version of diabetes out there. You probably had other people discuss on your podcast, and those are the monogenic forms of diabetes. And I would see kids sometimes who had monogenic diabetes who actually were able to get off insulin therapy, but they would be put on oral hypoglycemic agents. In fact, I have some patients like that now. In the past, we didn't have the way to do the proper genetic testing for those patients. Now we do, and we can identify them. And it's a very heterogeneous, diverse population of individuals, some of which can be managed with oral agents, and others that they go on to need insulin therapy relatively quickly. And last time I heard, there were like 14 different described cases of types of monogenic diabetes, but there are about two or three that are fairly common in the population. And we have testing for that. We do those tests here for kids that we suspect may have that because they don't quite fit into the type 1 model. They don't fit into the type 2 model. We still have to do the antibody testing, which is kind of core for diagnosing type 1 and LADA. And we do that. But that's another confounding version of diabetes that affects up to 3 to 5% of people, all people with diabetes.
Oh my, oh my. I have to look into that more. That's interesting. So is that generally something that is diagnosed in children then?
Yeah, absolutely. Usually in the second decade of life, if you look back, it used to be called maturity onset diabetes of youth,
Okay.
MODY, right? Now it's been
Yes.
changed to monogenic, and that was described back in the 1950s, around the time that oral hypoglycemic agents became available for clinical use. It was discovered that relatively lean people that had at least three consecutive generations of family members with diabetes, they could be taken off their insulin therapy of that time and be put on these oral agents, and they could survive without any need for insulin for at least 2 years. It was extremely clinical in how they diagnosed it. This is before they had any knowledge of genetics and all that. Fast forward to the 1990s, after the human gene code was cracked, we started to be able to diagnose these genetically. And now there are all sorts of genetic panels out there that if we have a suspicion of this, we can send our patients off to have those tests done to nail down whether they have a form of MODY, M-O-D-Y, monogenic diabetes, or possibly a LADA. But we always do the antibodies. In fact, they have to be antibody negative. To be a MODY, you have to be antibody negative. So that's
I
a test
see.
that we do for just about everybody. We have a suspicion of an autoimmune cause. But if that's negative, that may move them into the category of monogenic, especially if they have the genetic background, the heredity part I mentioned earlier.
Yes. So yeah, the auto antibody test, like that is a critical thing to distinguish the type of diabetes. Is that right? The
Absolutely. There's several different antibody tests you can do. The one that most commonly is associated with LADA is the GAD65 antibody, but it's possible others could also be there as well. So we do a panel. We typically do a panel of 4 or 5 antibodies to determine if there's any evidence of autoimmunity in our patients. We do that at diagnosis with everybody, even our type 2 appearing patients. We do that. It's just standard of care in most pediatric endocrinology practices these days.
Well, very good. Yeah, I think that is the difference sometimes between seeing like a primary physician and endocrinologist. Endocrinologist, they do the specialized tests. Primary care physician, oh, you have high blood sugar. Here's typically metformin, although now there's an assortment of medications. But it's an easy here, take this medicine. And they didn't do any antibody tests on me until I saw an endocrinologist.
So true. It's so true. We all get pigeonholed by our appearance sometimes, or our age in this case. We had the reverse thing that would happen too. We would find that a lot of kids with that were on the heavy side, they would be assumed to have, type 1 diabetes just because they're children, when in reality they have type 2 diabetes. We have a reverse bias there in pediatrics, similar to what a lean appearing or any size adult just has adult diabetes. Therefore, that's type 2, right? It just breaks down into this black and white thinking, unfortunately, because physicians and primary care people are rushed, and they sometimes don't always have as much of a depth of knowledge for the diagnosis part. Even though they may have lots of information about the various treatments that are available, all the oral medications, the injections, and so on.
Right, right. So type 1 used to be called juvenile diabetes, and I think they moved away from that and they found out type 1 can be diagnosed at any age.
Absolutely. When I was a kid, it was juvenile diabetes, and then for a while it became insulin dependent diabetes, IDDM. And that contrasted with NIDDM, which was non-insulin dependent diabetes. Those definitions really broke down over time into the current one we have now, which is basically type 1 and type 2. But if you really take a deep dive into the nomenclature, naming system, there's a type 1A, there's a type 1B, I saw recently type 5 diabetes. There are all sorts of different types out there that you can get off in the weeds on. I know we're not going to talk about that today, but that's it's an interesting area of study to look into.
Yeah, yeah. I heard about type 5 recently too. I think that was a new category.
Yeah, interesting stuff, huh?
Yeah, it really is. So so like high blood sugar is the symptom, but it doesn't tell you why. And then
And that's a great point. This is a teaching point. I'm going to put my diabetes educator hat on. I explain diabetes to some people as a destination. It's like saying you live up in the Northwest. Let's say, how many different ways can you get to Seattle, Washington? Well, there are many roads that come into the city. And so there, likewise with diabetes, if diabetes is just blood glucoses that are not properly managed by the body, how many different ways can you get there? Well, you could have a destroyed pancreas due to an autoimmune process. You could have resistance to insulin from a type 2 process. You could have a pancreas that just kind of self destructs, and that also sometimes is part of type 2. You could have a genetic disorder in how your body makes insulin. That's the monogenic form of diabetes, a single gene that causes a kind of an Achilles heel effect in the way your body makes insulin. And then you have these other conditions, like say you had your pancreas removed for surgery, you had trauma to your pancreas, you had pancreatic cancer, it had to be removed. Say you had high dose chemotherapy that damaged your pancreas. Any or all of those things will get you to a state where your body can't manage blood sugars, and you need to do something to attempt to manage that, whether that's insulin or oral agents or something. And so that's how I look at diabetes. Type 1 and type 2 are just different superhighways, if you want to use that metaphor, into the same destination.
that is a great metaphor. Yes. Yeah. So what do you think about like the journeys? I spoke in my book about like this. Well, the actual incident where I got high blood sugar was like the same as anybody who gets like type 1 diabetes, like where you're really thirsty and peeing a lot, like the classic symptoms. I also was losing weight. So that was sort of like a spike, like it happened suddenly. However, looking back before that, I definitely had incidences where I felt weird, like after exercise, I felt like, oh, I'm getting shaky, like my blood sugar is dropping. And then some foods that like raise blood sugar quickly, I didn't like eating them because I'd feel weird. So I felt like that I was already having symptoms, but it wasn't recognized. Like my A1C was okay then, my fasting blood sugar test was okay. And then all of a sudden, like everything went crazy, and I had really high blood sugar. And so I went to the doctor. But do you see that kind of thing where there can be something that happens before the sudden diagnosis? Like, anything that's common there for you?
Absolutely. That's a well-described phenomenon. You get this dysregulation or abnormal regulation of insulin production. Basically, we see that hear stories like that with both forms of diabetes. The ability of the pancreas the beta cells specifically to release insulin starts to get sputtery. They just don't do it as quickly. In fact, in some ways, you could liken it to this. I have an argument for this. There are two phases of insulin release from the pancreas. There's first phase insulin release, which is insulin that's already stored in your pancreas, ready to go. It's already in there. Okay. And then there's second phase insulin, which is insulin that has to be created from scratch. Okay. And so first phase insulin release is often compromised early in the course of diabetes before the clinical stage. And so then you have second phase, but it lags. So imagine you get a surge of blood sugar, you trigger your own second phase response, and then you get almost like it's kind of like an insulin stack on a pump or a shot. Then you get a low an hour or two later. The same kind of thing happens with type 2. I can't say it's for the same reason, but you get this dysregulation of insulin. You get insulin at a time when you probably don't need it, and it's causing some low blood sugars. But no, that often predates any of the other outward symptoms you describe, like increased thirst, urination, and or weight loss. And that applies also to type 2 diabetes, just low blood sugar effects. It could happen years before you ever get diagnosed with type 2 diabetes.
Okay, and I get that. That's interesting. A two-phase delivery of insulin, making it. Yeah, that's understandable about how the body works. That's really interesting. So misdiagnosis is common. There's a lot of people that get type 1 or later in life. Is there something that people should really do if they think they were misdiagnosed and they haven't had the proper tests? Like, how should they go about trying to get the right treatment?
I think that what you're doing to raise awareness about this is one of the best things I've seen in a long time, because you and I both know that type 1 diabetes, autoimmune diabetes, whether it's LADA or juvenile type 1, whatever you want to call it, happen, a significant number get this after age 21. I see numbers as high as 50 to 60% of people with what we would call type 1 diabetes or LADA get it after age 21. Okay. So it undermines the diagnosis of type 1 diabetes being a children's disease. It's pretty much an all ages disease, and people need to be made more aware of that. So they do these definitive tests, do these special antibody tests when they get anybody that comes in for high blood sugars, regardless of what they look like,
Right.
because I have been surprised when I've seen children I would have thought may have had type 2 diabetes. And in fact, if you look at the data from all the studies in the last 20 years, roughly 10 to 15% of children that have diabetes that would otherwise appear to be type 2 with insulin resistance and being overweight and such actually have markers, antibody markers of type 1 diabetes. And that creates a whole lot of discussion about, well, what type are we going to call this? Is it type 1? Is it type 2? Is it somewhere in between? And there are people you can get on this podcast who will go into great detail about how they like to label that, whether you call it a 1.5 or a 3. There's just all sorts of different ways you can frame that. But checking those antibodies, to me, seems to be an essential thing to do with anybody who's an adult that gets diagnosed with diabetes, so you don't miss the autoimmune component. Again, taking it one step further with the monogenic, that takes another level of appreciation that I'm not sure, that's a little bit more tricky, because say you do have a negative antibody, okay, and you think, oh, there they go, they're just a type 2 diabetes patient, right? But you're not ruling out at all the monogenic form. You have to ask some more questions. You have to look at the patient a little bit more deeply when you get to that point. That's a whole nother discussion, I realize, but there's a lot more to it than just the antibodies.
Right. Yeah. Okay. So when you get the right diagnosis, then I guess the thing is then insulin, right, is what people need if their body's not making enough insulin. But it's tricky to dose the insulin correctly, which is what your book, Sugar Surfing, and that concept really helped me figure out, because blood sugar changes all the time. And it's also mentally a lot of times kind of scary if you have gone from not knowing anything about blood sugar and then having to manage this thing that changes all the time every time you eat. And I see a lot of comments like people are afraid of insulin too. So I also am thinking maybe people really don't want this later diabetes diagnosis. Like they'd prefer to be type 2 because then maybe they can just do it without insulin. But can you speak to a little bit about like when people need insulin and about starting insulin?
Yes, as this condition progresses, it progresses more gradually in many people. You can have it present for possibly years before you would reach the stage where you start getting any symptoms. You could still have borderline abnormal blood sugars and not really pick up on it with the classic symptoms. So it can be gradual. It's known to be gradual. Uh, we already know from prevention studies that we can identify these markers for people with type 1 diabetes in childhood years before they get the first sign or symptom. And in people that are older that are going to get it, it could even take longer. So what's the threshold? Okay, well, there we have all sorts of limits like A1C levels. With our A1C level is going up, you can debate whether a 7% A1C is too high or a 6.5. It's time to implement insulin. And then what kind of insulin would you implement? Are we just talking about a single long-acting insulin, like a basal insulin, like Atlantis or a Tresiba or something like that? So you have to curate the treatment based on the individual history and the findings for that particular patient. How far along are they? How long have they been missed, so to speak? And what do you think is still left? And so, obviously, the first job of medicine is to do no harm. But also, you will do harm if you don't put somebody who needs insulin on something. And yes, there's a huge fear factor out there. There always has been all the years I've known it for insulin. There's this bias that lingers in the human population about, well, if I go on insulin, something bad's going to happen to me. I'll wind up in the hospital. You know, my Aunt Minerva went on insulin and something bad happened to her a year later. I'm not going to do that insulin thing. I have heard that my entire career. So there's a lot of education that goes out there to explain how diabetes works, how long it takes to get to certain phases of your diabetes. It's not like a light switch got flipped and all of a sudden you have diabetes. In many cases, it's been happening over a very gradual period of time. Both types, both types. Obviously, type 1, we think about happening a little bit more quickly than type 2, but both types happen. And it even happens fast in kids with type 2 because if you think about it, we're seeing 14-year-olds with type 2 diabetes when in the past, it used to be 40-year-olds who were getting it. So certain things have changed. That have made this diagnosis come on sooner in our population than it did 30 or 40 years ago when I first got into endocrinology.
Yes, yes. Do you think that's like obesity epidemic or something else?
At least partly, I think you have a good point about something else. I don't think we know for sure what the other things might be. We certainly, the obvious thing is maybe the epidemic of, weight issues with boys and girls and with the adult population may put an additional strain on the body's ability to make insulin. And we also know that being overweight and having a lot of body fat mass, that's an inflammatory state. And inflammation is not our friend, whether we're talking about our heart, our brain, or our pancreas. And chronic inflammation, it's like it erodes the well-being of these organs and their ability to function normally. So we know that inflammation does play a role, but we also know, as I mentioned earlier, the hundreds of genes out there that are acting alone or together, which can contribute to this. It's a very complicated set of circumstances. And it's one of the reasons we call type 2 diabetes polygenic. And frankly, type 1 is polygenic as well. When you look at all the genetic associations, we know how to treat the end result. We know how to identify people who are about to get there. But going way back to the beginning, that's still a great area of research. Granted, we have treatments now to slow it down, but we've yet to have something that completely stops it in its tracks, especially type 1 autoimmune diabetes.
So polygenic meaning many different causes. Is that what that
Many
means?
different genes that are in play. Yeah, many different.
And yeah, and to as far as the tests, I know I've heard that you can get tested to see if you might get type 1 diabetes later in life, even if you have no symptoms. That's sort of become more common that you can get a blood test. And if you maybe you have type 1 diabetes and you have a child, you can get them tested, right?
Right.
And I
You can go to
imagine,
Trialnet. You can go to Trialnet. Trialnet.gov and request a kit. There are different ways online you can get that done and get you or a family member checked for these antibodies, and that's a free screening program. And then you get the opportunity to perhaps participate in clinical trials, which may be able to, delay the onset. And TrialNet has been around for decades. It's a national program, so your viewers might look at trialnet.gov and see what's available in their area.
Okay, so there's some hope in delaying type 1, but there's nothing that totally prevents it today.
There is a delay, and maybe your viewers know about Tzield or Teplizumab. Teplizumab is a monoclonal antibody. It's one of these biological medications. It's been around for decades, but in the last couple of years, it's been approved for use for delaying the progression from what's called stage 2 diabetes to stage 3 diabetes in people with type 1 diabetes. People that have at least two antibody markers present and evidence of some sort of abnormal blood sugar, but not yet quite to the level of being labeled as having diabetes. That's the definition of stage 2 diabetes. And if you can intervene at stage 2 and delay the onset of stage 3, which is clinical diabetes, then you potentially have really made a difference in that person's life, even if you haven't stopped it altogether. And a lot of research is focused on this and other approaches to stop it as early as possible, or at least slow it down until we have a way we can stop it or arrest it.
Okay. And going back to LADA diabetes, like what is the difference between that and like being in a stage 2 of type 1 diabetes?
Well, diabetes, if you were at the point of having LADA diabetes, you have stage 3 diabetes. Okay, you have clinical diabetes. You still have abnormal glucose tolerance. Okay, but even LADA diabetes will actually have a stage 2. They definitely will.
Okay.
So, in fact, LADA diabetes patients are eligible for these studies, and they're eligible for this treatment.
Terrific.
Anyone 8 years and older can be treated with Tzield. It's Tzield. Teplizumab is the generic name for it. And that is a target population to use this medication. And in fact, it may actually have a more dramatic effect on people with emerging LADA. If they know they have it, they got the antibodies before they've developed clinical diabetes. So that's a tricky thing to balance with LADAs because, for one thing, they're hard to diagnose to begin with after they have diabetes, much less picking them up beforehand. So you would have to be in a situation where you had family members that had diabetes, LADA or otherwise, and you went and had your blood test done through TrialNet, and you turned out positive while you still had a normal A1C. Okay. Now that's a bit of a tall order for somebody to be that proactive and thinking that far ahead. But if you were to be one of those people, you would be just as eligible for doing that as if you were a child, a sibling of a known patient with type 1 diabetes who did the testing to see if they were at risk.
Okay. I see. Yeah. So it has to be, yeah, most people probably have that abnormal A1C by the time they are at their doctor's office. But if they had a family member, maybe of type 1 diabetes and they got the screening or something like that, then yeah, they might be
Right. You have to
get that.
fall in this. You have to fall in this zone. You have to have an A1C that's not yet at the diabetes range, or a glucose tolerance test, a little bit more formal, which is in the pre-diabetes range. So you have to be identified as a pre-diabetes patient with two positive autoantibodies, two of the 4 or 5 that are available. If you meet that criteria and you are over 8 years of age, you would be an eligible patient to receive this medication called teplizumab. Now, this is something that's infused over 14 days, 14 different infusions. It's a fairly laborious process, but it has a track record. It's been done for years and years and years, and it finally got approval, FDA approval. It's expensive, But insurance companies are covering a large proportion of the costs, and it delays the onset of the clinical onset of type 1 by approximately 2, maybe 3 years. It varies according to the individual patient, but the average is delaying clinical onset of full-blown stage 3 by 2 to 3 years, and more importantly, preventing DKA. People that get this medication almost never go into DKA because they're so on top of everything. They're not going to be caught off guard.
Yes. So DKA, diabetic ketoacidosis, like a life-threatening condition. And sometimes people get type 1 diabetes and they end up in the hospital with DKA, right? Because it comes out of the blue, right? And they don't expect it. And that's very scary. Yeah.
Right. And DK is never on anybody's radar screen, unless you have an immediate family member who's been through it. I'll say this, and it's not 100%, but of the children I've taken care of, I've always said that if a second child develops diabetes, this is before we had antibodies and all that, we were routinely doing, that it's unlikely the second child goes into DKA because the parents often will identify the signs and symptoms in the son or daughter and use the home equipment and check. Now, I have two examples where that didn't work. That still the a sibling got it and went into DK, but that's the exception to the rule. The rule is most of them are picked up very, very early because their sibling has it, and the parents are real attuned as to what to look for.
Right. The parents recognize that their child's sick and it might be diabetes, and it's because of,
Absolutely.
yeah,
Absolutely. Spot on. Spot on.
yeah. Yes, I think that's why we need so much awareness of, like, if you're really thirsty all the time and you're peeing all the time and you're tired and you're hungry and stuff like that, like this could be very severe. What's going on? You need treatment.
Exactly. Exactly.
Right, right. So I think with LADA diabetes, once you have LADA diabetes and you're on insulin and stuff, I think the next thing that can trip you up is that all of a sudden you need more insulin because you're past that honeymoon stage, and you might be like, what's going on? Your blood sugar's going up higher, and you're like, I haven't changed anything. I don't know why this is happening. So
I the people I see with LADA who are in the late teens or early 20s that I follow now, um, one silver lining, if you want to use that metaphor, is that many of them are a little bit more mature. They think like adults as opposed to a 12 or 13-year-old child who's still going through adolescence or even younger. And so they are more likely to take more responsible actions for self-management. I won't say it's 100%, nothing's 100%, but it does give them their developmental age gives them a bit of an advantage in managing this. I saw a young man just last week who I've been following. He's about 24, 25 now, and he's doing very well. He's 2 or 3 years out from his LADA, very well managed, uses MDI and a CGM and sugar surfs and all that. I have patients also that wear pumps, and to me, it doesn't matter which way they choose as long as they make great decisions. And I find that many of the ladies make very nice decisions. They're more mature about their diabetes as a group, but everyone gets anxious in the world, and everybody hears all these horror stories, like we said before, about insulin. So part of getting through to people to help them is to get them over these fears and address them head on and answer people's questions as forthright as you can to dispel that. Now, of course, I have an unfair advantage. I've been on insulin for 60 years. And I can say, well, I'm fine, and if that's just an anecdote, that's not science. But I also, and this too, there are many people like me who have lived with type 1 diabetes since the dark ages, who have had it 50 to 75 years. I have a lot of friends like that. And we didn't have all the fancy equipment and all the technology that everyone has now, but we made it. We made it back from the dark ages. So I like to use that as some source of encouragement, that think how much better you can do now than we did, because you do have all these tools. You do have all this knowledge. You have this collective experience that can help you moving forward and possibly outlive us and live longer than people without diabetes. I think that's altogether possible.
Oh, absolutely, sure. And I also think there's domino effects beyond like you're managing your blood sugar because you want to keep it in range because you don't have these long-term side effects. But to do that, you have to be very self-aware and you have to give yourself insulin when you eat food and go to the doctor for follow-up. Anyway, there's all these things that you're doing to try to manage your blood sugar that also probably help other areas of your health, like your heart health, perhaps, and this general self-care mentality. And I think it can be a very, very good thing to, you're taking time to take care of yourself, and that really can bloom out to like all these other areas of your life.
Prevention, and I'll underscore that for your listeners. Prevention. In my daily routine, I'm always screening my patients to make sure they've had a retinal exam in the last year or two, that they see their get proper dental care every 6 months. We do annual screening labs for other autoimmune conditions that are known to occur more frequently in people with type 1 diabetes. We monitor blood pressure. We monitor cholesterol levels. We monitor thyroid levels. We look for celiac disease. And from time to time, we'll diagnose patients that have these years after they've developed their diabetes. And if we didn't, these too might go undiagnosed, and a lot of discomfort or pain and suffering for patients who don't get diagnosed with these things. So I cannot underscore prevention more than that. And as I get older, and I saw a cardiologist as I got older at a younger age than most people would see a cardiologist. Of course, ophthalmology. We all know that I mentioned earlier, eye exams. I want to make sure my retina is good and my vision's okay. Kidneys, we screen for early signs of diabetic nephropathy with a simple urine test. And so we're always looking for these things at a stage when they can be reversed or slowed down. That's the goal of prevention. And I dare say that most people with diabetes, if they're doing this properly, are getting a far more preventative care than other people their same age that don't have diabetes or any chronic illnesses.
Yes, yes, I can totally see that. Yeah. So that is, yeah, prevention is definitely key there, and the diabetes might be the driving force of making sure you're doing all that prevention.
Correct. Absolutely.
Now, I feel like I need to ask about GLP receptor agonists because I hear about them now like all the time, Ozempic, Mounjaro. Are those appropriate for people with LADA diabetes at any time?
You mentioned you've been keeping your finger on the pulse of the research community quite well. If so, then you've seen studies that have included classic type 1 patients with the GLP-1 agonists, the injectables, and even some of the oral stuff. And they are being explored as therapies to facilitate blood glucose management, not to replace insulin, but to facilitate other aspects of care, such even cardiovascular disease. And of course, one of the uses of this medication in recent years has been for weight management, as you know. And but it also has a spillover effect on glycemic management as well, blood sugar management. So yes, there are lots of studies that have come out in the last 10, 15 years with these agents being used in people with type 1 diabetes. Now, I don't routinely have a lot of patients with type 1 on them. We have a few in our practice, but it's not a routine thing that we use in our type 1 population. Yet there is literature, certainly in the adult population, of it being potentially useful and beneficial.
Okay. Yeah, I have read about it and I've been wondering because I know the pancreas, it really doesn't only produce insulin. There are other hormones it produces, and there may be, some misbalances there as well.
Correct.
Anything else comes to mind when you're thinking about LADA diabetes that you think people need to know about?
I think that the LADA patients I've seen or known personally or helped manage, uh, I think that because they're diagnosed older, generally a lot of them are, they do have an advantage in terms of being able to approach their diabetes early on in a more mature way. Doesn't mean that's going to happen. I think though that it tends to be it tends to be a little bit more gradual in its progression. The honeymoon phase we talk about, there seems to be a longer one if you want to use that term. There is a formal definition for what honeymoon means. I'm not going to go into it, but people with LADA tend to hang on to their insulin capability longer. They didn't lose it very quickly. Imagine when I see a 1 or 2 year old with type 1 diabetes, imagine how quickly they lost the ability to make insulin from the time they were born. We're talking about people who are now in their 20s and 30s and 40s. And how long did that take? Well, it's really kind of hard to know completely well because you don't know when the first step started. How far back in my friend who was 55, I mentioned earlier, when did her process of beta cell decline occur? Was it when she was 35? Was it when she was 40? You can only speculate. But it takes longer. And so having beta cells longer and an intact pancreas longer is a good thing to have. I'm not going to debate that one bit. Like I said, it's the flip side of that. It creates all this confusion with getting a proper diagnosis. And I think anybody with LADA needs to make sure that they share that information with their doctor, and that doctor knows their primary doctor especially. They may actually see an endocrinologist, but it's not a bad idea if they have a primary doctor to make sure that doctor is educated by that patient about what LADA diabetes is. So the other patients in their practice don't get delayed in their diagnosis. So you can take an advocacy role as a patient within your own particular medical practice. I think that's altogether very realistic and something people should consider doing.
Right. Yeah. Spread the information, share it. Hopefully, doctors are open to learning about this. Uh,
Absolutely.
is there anything that you could do personally, though, if you are, you're in the honeymoon stage and you're still making some insulin to try to prolong that honeymoon stage?
Well, I think maintaining the optimal level of management, using a CGM if that's what you use. If you choose to use an insulin pump, that's great too. The choice of management to me is whatever best fits that person's lifestyle and needs as a person. I think that if you throw all caution to the wind and minimize your involvement in your own self-care, what's going to happen, obviously, is you're going to tend to run higher blood sugars. And what my bias is that if you're pushing that what's left of that pancreas harder, you're going to burn it out faster. You're just not going to, it's not going to last as long than if you nurture it along and help it along by working on your body like it's a hybrid car. Part of it's your insulin and part of it's external insulin, right? And I think that has a lot of validity to it. And I would certainly endorse that. So don't throw all caution to the wind and say, well, I'm just going to do whatever I want to until I absolutely need to, be on something more aggressive. No, do the best you can from the get-go. And I think you'll extend the life of that remaining pancreas. Now, and I don't know the current studies for LADA in terms of interventions, but there have been some, recent interventions with medications to try to extend the life of beta cells. I can't speak to them real knowledgeably right now, but one that came to mind was Verapamil, which is a calcium channel blocker. I don't know if there's how strong that data is, but it's an oral medication. There was also another one called Baracetanib. It's an enzyme inhibitor of some sort. Your readers can look it up, but there are some things that have been looked at to try to extend the ability of the pancreas to make insulin after the diagnosis of stage 3 diabetes. And that's kind of where we're at right now. Identifying the stage 2, as I said earlier, is the domain of trying to use these monoclonal antibodies to see if we can delay the onset of stage 3. And there are actually things being done for stage 1 diabetes, which I won't get into, but this is a whole world into itself. You might find an expert to talk to about all those intervention studies, and it'd be a fascinating episode for you.
Okay. Yeah. I'll have to look into that. Yeah. Yeah, there's a lot of research going on. Like it's a very active area of new treatments and figuring out things. So there's a lot of hope really with diabetes today.
Absolutely. Absolutely. And the one thing that you probably talked with other presenters is the whole transplant issue, the stem cells, and the gene editing of pluripotent stem cells. That's a whole nother arm of the diabetes world aimed at trying to quote unquote cure diabetes. And there are all sorts of exciting little studies that'll be reported and such. Um, I'm kind of circumspect about the whole thing, and I'll just give it, this may be the most controversial thing I say today, but my view on a cure, which I've heard for 60 years, there'll be a cure, there'll be a cure, there'll be a cure. Well, a number of years ago, I looked into what does cure mean? Okay, there's a definition for that. We use a word that has a definition. If you look at the word cure, it comes back from Latin times, okay, Roman times. It had three core meanings. It meant you attended to somebody, you were concerned about somebody, and you cared about somebody. And so when you were being cured from a disease in ancient Rome, somebody was tending to your needs. They were bringing you food, they were bringing you water, they were giving you shelter, they were keeping you warm and all that, while your body healed itself, right? But that's where the word cure came from. It never was meant to be eradication of disease because we didn't look at disease quite the same way. We have kind of reassigned a new definition to that term over time. But I would say this to parents all the time at the camp that I run. I said, how many parents do not care about their children's health? How many of you don't attend to your children's needs? How many of you don't care about your children's well-being? Well, nobody's. They said, of course, none of us. Okay. Well, you're curing your child every day. You're doing all three of those things. That's why your child is still alive. I have been curing diabetes for 60 plus years. Okay. And I think that's not to be underestimated. That's because of the choices I made, the decisions I made, being blessed to live in this country, in where we live, where I had access to what I needed, blessed to have family that cared for me, parents that cared for me, physicians that cared for me, health team that cared for me. And so I count my blessings all the time for why I'm still here, as probably you do, and many of your your watchers do too. But my attitude of a cure is people want whatever we want to make diabetes go away. We want it to be instantaneous. Wouldn't that be nice? Just go away. Okay, I can go to the OR and cure it. They want it to be non-invasive. Wouldn't that be nice? Don't leave any scars on me, right? I want it to be pain-free, okay? I want it to be accessible anywhere in the world or I go. I love it to be oral, right? A pill or something. And I want it to be durable. I don't want to have to take another treatment in 6 months to keep it going, okay? And the bottom line is, I want it inexpensive. I want it cheap. Now, think about everything you've ever heard about a cure for diabetes and use those criteria. Where do they fit in that checkbox list? Okay. Think about the things we can technically cure now. There are a handful of things we can cure in medicine that literally we can cure. If you look at the price tag for them, what is that? More than you and I am probably making a lifetime. I mean, and we hope our insurance companies pay for that. Well, think about how that system works. What if the 2.8 million people with insulin requiring diabetes get cured and they each cost whatever that costs? The healthcare system can't sustain that. Okay. And then who are we going to pick? Who are going to be the lucky people, the elite people that get this? That speaks to issues of inequity. You know, why do you get it and my child doesn't, right? So that's my controversial comment about this because I've thought about that for decades and even more so lately when people ask me about cures all the time. I say, focus on what you have now. You have more than enough equipment and technology and knowledge to do well now, whether that's with automated insulin infusion devices, you know, the bionic pancreas, CGMs with sugar surfing, MDI. And I maintain a 98% time in range with this insulin pen and my CGM. I was on a pump for 35 years. So it's within reach. Now, whether it's that person can do it or not, that becomes the issue. Do they have the support system? Do they have the belief in themselves? Do they have the right attitude, if you want to use that word? And but there are people out there like me and like you who are doing this. And I think others like us can do the same thing with enough encouragement, okay, and support, okay. But it would be nice if we just wave a wand and make this all go away. But there are lots of caveats written into that, as I just alluded to: cost, availability, ease of use, the durability, all of those things. So we could have a whole session on just about curing diabetes and the ethics behind all of that.
Oh, yeah. You bring up a lot of interesting things to think about. I use the word cure in one of my videos, and then I sort of apologized for that. But I was thinking about the fact that if I was born like 100 years ago, there was no treatment, and you would die. So to me, I mean, I know it's not what a lot of people want when they say cure, but it's like I'm really grateful to be alive now. So, and coming from a place of gratitude to have insulin, a CGM, knowledge, yeah, people helping me out. I mean, and I, I mean, it's a challenge, but hard challenges are how you grow, and there's life is full of challenges. So even something that is a difficult challenge can really be positive in the end. I yeah, we would not want to cure if it's like only a few elite people can get that cure. And today there's still problems with some places in the world where people can't get insulin. So I mean, let's focus on insulin for everybody, right? So
Exactly.
yeah.
Exactly. Think about this. 1966, that was the year I was diagnosed, but that was also the year, I believe, that the first pancreas transplant was ever conducted and successful. I'm not sure how long the patient lived, but a pancreas transplant is by definition a cure. Okay. But if you apply some criteria to that, is that a cure is that the kind of cure you want? You have to take a handful of medications to keep your body from rejecting it. It's a major surgical procedure. And these days they're often adding a kidney. It's usually a kidney and pancreas transplant, but it is a cure. And you do not take insulin anymore. You take other things in its place. You might call it a trade-off cure, right? It's a trade-off cure. But so we have to take a hard look at ourselves when we just say we want a cure. What does our cure look like? And if I asked you to write a list of things down before we talked about this, I'd be curious what you would have written down, what your definition of a cure is, what your expectations more appropriately of a cure might be.
It's a good mental exercise to think about
Yeah,
that.
I do it all the time.
Well, this is great. You have shared so much information. And so thank you for taking the time here. If
It's a
people
pleasure.
want to, oh, what's that?
It's a pleasure. It's a pleasure. I've enjoyed chatting.
If people want to learn more, where should they go?
Well, there's a lot online, but I have the Sugar Surfing site, and it has a lot of my experiential wisdom that I put in blogs over the years. It's still there. It's sugarsurfing.com. And I'll be straight up with your viewers. I've not put something on recently because there's really not as much new stuff for me to put out there. Sugar surfing is sugar surfing. And I use this metaphor a lot. Also, another metaphor is when the Wright brothers invented the first airplane. They didn't get into the airplane building business. They didn't become Boeing or anything like that. And you know that from where you live. They opened a flight school. They opened a flight school. And so to me, when I wrote Sugar Surfing, it wasn't about CGMs. It wasn't about, a device you were using or what brand it was. Heaven forbid that was 10 years ago and all those systems have been upgraded. It was what do you do with the information you get from that device? How do you make cogent decisions with that information about your self-management? That was the whole concept behind Sugar Surfing. And I knew that when I wrote the book, that I wasn't trying to keep up with the Joneses and write a new book every year to keep up with the new CGMs that were coming on the market. It was how do you use that information? So to me, just like the principles of flight are kind of timeless, they don't change. Sugar surfing, sugar surfing. And if you look at it a little bit closely, you'll notice that all the automated insulin diffusion devices, AIDs, they're sugar surfing machines. That's what they are. They still require some human intervention. It requires a little bit of sugar surfing knowledge, but they have basically incorporated the things I wrote in that book into their software, their algorithms to manage glucose levels using sensor data. I just wrote about how to do it manually. That's all I did. So how to drive a stick shift, so to speak, as opposed to the automatic transmission or the Tesla driving you around, that sort of thing.
Absolutely. Yeah, that's actually funny because I got a pump that does automated stuff. And at one point, I was reading your book and I was like, I have to put it in manual mode because I can't sugar surf if it's doing the decision making. You can't have two brains. You're either manually doing it or you're letting the algorithm do it for you. And then my current pump, I can do a little bit of sugar surfing while in auto mode to an extent, but yeah, there's some times where it's like I have to put it in manual mode if I really want to take control of it.
I think there's some things, and I got another metaphor for you. Yeah, you probably have a cruise control in your car like we all do.
Yes, yeah.
You turn that off all the time. You like to park your car by yourself and use instead of letting the machine do it for you because you feel like you can do a better job. So there are times when the technology is great and allows you to take your mind off your diabetes. You can focus on the other things you want to spend time on. And there are times you want to turn off everything, turn off the autopilot, and go into manual mode and do what you want to do to manage something that the machine may struggle to still do.
Absolutely. Yeah, that exactly is the metaphor. Yeah, cruise control. It's like I have adaptive cruise control, but sometimes I just have to run it myself. So awesome.
Good
Cool.
point. Good point.
All right. Well, thank you, Dr. Ponder.
My pleasure. Thank you so much for inviting me. Appreciate it today.
Have a good one. Bye.
You take care. Bye, Lynn.